Thank you for joining me today for the webinar on Preventative Care Billing in the FHO. My name is Maral Sanassian, and I'm a consultant on the Healthcare Consulting team at Cirrus Consulting Group. It's great to see so many people that have logged on today. I would like to let you know that we will be recording this webinar, and it will be available on our website. I will also follow up individually with each of you at the end of the webinar. I'm going to ask that you please hold your questions until the end of the webinar. There is a chat box on the screen, which will enable you to send me any questions you may have. The reason we decided to run this webinar is because we tend to get a lot of questions on preventive care billing and best practices. And by now, you would have received your preventive care reports from the ministry, and most physicians tend to bill over the summer months. The purpose of today's program is to walk you through the preventive care program from a billing perspective, to update you on the latest ministry changes to the program, and to provide you with one-on-one support on how to bill this area properly. Preventive care bonuses make up roughly 2% of a FHO physician's income in Ontario, which may seem small. However, it is an important piece in providing quality care to patients, and we want to make sure that the work that you do is reflected in the preventive care bonus that you get. A couple of quick facts about the preventive care bonuses. $12,800 in bonus potential exists for high preventive care screening and vaccination levels attained in specific categories. The average physician in Ontario will earn about $8,500 in bonuses. Bonus levels are based on the percentage of patients screened or immunized who are demographically targeted. So for example, with mammography for breast cancer screening, if 75% of women at risk, so those between the ages of 50 and 74, are screened for breast cancer via a mammogram, the physician is eligible for a bonus of $2,200. There are two categories within the preventive care bonuses. There's cancer screening, which includes Pap Smears, mammography, and colorectal cancer screening. And then there's the vaccination program with the Influenza Vaccine and childhood immunization. Each preventive care category has its associated billing and tracking codes. As a best practice, we do recommend that you submit a tracking code with all preventive care services provided, since not every category does track the services automatically. And I've put here the summary of the billing codes and the associated tracking codes for the five categories. We're going to take a look into the breakdown of the preventive care categories. We'll note down the different thresholds and the percentage levels that you need for the bonuses to kick in. Note the exponential nature of the bonuses. Even a 5% difference makes a significant difference to the bonus attained. So there is an incentive to provide preventive care to your patient population. If you find that a physician is close to one of the higher thresholds, it's worth their time to look through the charts and contact any remaining patients that require preventative care. For the 5 categories, I will also walk through the target population, so the demographics that will be targeted, the service interval, what the service is and what interval it needs to be performed in, any exclusions, so what characteristics exclude a patient from the category. So for example, if a female with mastectomies are not required to have mammograms, and any challenges that are often faced by physicians. We'll start with the influenza vaccine category. The target population here is everyone 65 years of age and older. The tracking code is the Q130A. As for the service interval, it's 1 flu shot annually per patient, performed before January 31st of the fiscal year for which you are billing your preventive care bonuses for. There are no exclusions for this category. However, some of the challenges frequently faced is that some people refuse a flu shot on the basis of previously having been sick as a result of it. And also more and more pharmacies are providing the flu shots without communicating this back to the family physician. The target population for the childhood immunization program are infants between 30 and 42 months of age. The tracking code is the Q132A. With regards to the service interval, it's all patients who have received the immunizations as recommended by the National Advisory Committee on Immunization by their 30th month of age. There are no exclusions for this category. One of the biggest challenges that physicians come across is that patients refuse immunization on personal beliefs. Pap Smear for the cervical cancer screening program has a target population of females between the ages of 21 and 69 years of age if they are sexually active. The tracking code for this program is the Q011A, and the service interval is one Pap test every 3 years. Exclusions exist when the woman has had a hysterectomy or they've had cervical disease which does not allow for regular Pap screening to occur. If either of these exclusions are reached, then the Q140A exclusion code should be billed for the patient. Some of the challenges in this category is through cultural barriers. So for example, when women do not want to be seen by a male physician to get their Pap smear done. With regards to mammography for breast cancer screening, the target population is now females between the ages of 50 and 74 years of age, and the tracking code is the Q131A. The service interval is one mammogram every 2 years, and the patients that would be excluded are those that have had a mastectomy or that are being treated for clinical breast disease. If either of these exclusions are met, then the Q141A exclusion code should be billed for the patient. There is a minor challenge here, and that is that patients screened in the Ontario Breast Screening Program clinics do not show up on the ministry reports, but the program does provide reporting. For the colorectal cancer screening program, the target population is males and females between 50 and 74 years of age. The tracking code is the Q133A. The service interval for this category is one fecal occult blood test every 2 years. Patients that would be excluded from this category would be those that have known cancer of the bowel, that are being treated for inflammatory bowel disease, or that have had a colonoscopy within the last 10 years. If either of these criteria are met, the Q142A exclusion code should be billed. Some of the challenges that we come across within this particular category is the stigma of undergoing colorectal cancer screening. And there exist cultural and religious barriers to overcome as well. And just going into a bit more detail with the fecal occult blood test, it is a test for trace amounts of blood in the stool, which can be an indication of colon cancer. It is an at-home test performed over 3 days, and it is only tracked once the patient submits the FOBT kit with regards to the tracking code for this category. Now we move into the actual logistics. In order to receive their preventive care bonuses, physicians need to, 1, calculate the screening levels individually within each category, and then submit the appropriate billing code for the level of screening they reached within that category. So for example, if a physician screens 75% of the women in their practice for breast cancer, they'll submit the Q114A code. What's different in the Preventive Care Bonuses program as opposed to the Special Premiums program is that with Special Premiums, the services accumulate automatically and the bonuses kick in automatically, whereas with Preventive Care, it's important to go in and manually do the calculations and then submit the appropriate billing code. So let's first look at what we need in order to calculate the screening levels individually within each category. The major piece of information we need comes from the ministry reports. The ministry reports are issued twice a year. In April, you'll get the previous and the projected preventive care target population and service report, which you should have received recently. And in October, you'll get another projected report, which is an updated report from the projected report that's issued in April. These reports list the patients in each category and whether or not they have a known service date within the service interval or whether they have been excluded. A question we often get asked is, what is the difference between all these reports? The previous report that you receive in April is the one you will use in order to bill the preventive care that you've provided to your patients for the previous fiscal year. The projected report in April is to assist you with providing preventive care to your patients within the coming fiscal year, as it captures the patients that qualify for preventive care. The projected report that is issued in October is an updated version of the April projected report so that it reflects any mid-year changes to the target population and preventive care services provided. This is what the previous report looks like that you would have received in April, an example of it. And so as you'll notice, there are the patients listed, and then there's a service date column at the right and then an excluded date column. If a patient has a service date listed, then they've been screened or immunized and they should be included in your bonus calculation. If they have an exclusion date listed, then they should be part of the number of patients that are excluded from the category. If there is no service date by a patient's name, then it's important to go into your EMR or your records and pull up the patient history to check if they've received the service or not. And this is where tracking codes are very important. If you track with all preventive care services that you provide, then the ministry reports will be more up to date when you receive them. Now, going into the actual calculation of screening levels, you're going to need 3 pieces of information. You'll need the number of patients within that category, so the target population, the number of patients that have been screened, and the number of patients that have been excluded. So first, you'll take the number of patients screened. You're going to divide this by the difference between the number of patients in the target population minus those that have been excluded. You're going to multiply this by 100 in order to get the screening level percentage. A question we often get asked and is important to note is that if patients decline a service, they are not excluded from the target population. Patients will only get excluded if they fall within the exclusion criteria as set out by the ministry. So we've taken an example of calculating screening levels. If the number of patients within a category was 1,100, and we had the number of patients screened to be 750 and 100 to be excluded, we'll take the number of patients screened, the 750, we'll divide it by the difference between the patients in the category, the target population, minus those that should be excluded if they've fallen under an exclusion criteria. We'll multiply it by 100, and you'll get the screening level percentage. At this point in time, once you've got the screening level percentage, you can go and submit the appropriate billing code for the level of screening that you've provided within that category. This is a Cirrus cheat sheet that we've got on our Cirrus Physician portal as well as that we provide in person. The back page, as you can see here, contains detailed information on the preventive care program. It's got the tracking codes, the exclusions, and it also contains the different billing codes for the different thresholds of preventive care provided across the 5 categories, and is a great tool when billing the appropriate code. Once you've submitted your preventive care billings, you will see that it will kick in once you see it on your RA. It is important to note that this section always reports the previous fiscal year's attainment that was billed and paid out. It's useful to look usually between April and September of a given year to ensure that the bonus has been paid out. I wanted to address some of the shortfalls with the ministry reports that are typically used when you calculate your preventive care bonuses. The ministry reports really are a starting point for calculating physician attainment because they do not capture services that are provided that are not directly billed to OHIP. So for example, the flu shots through a pharmacist or mammograms performed at an Ontario Breast Screening Program facility. There are services that slip through the cracks and are not billed. And not all categories track automatically. Some do and some don't. So it is important to keep this in mind, and it is great practice to track preventive care services of your patients as you move along. The one thing I also wanted to discuss is that Cancer Care Ontario with the Ministry of Health now has a new screening activity report that they are offering through an online portal called OneID. This offers a comprehensive summary of your patient's breast, cervical, and colorectal cancer screening history. I've put a snapshot of the dashboard of what part of the report looks like. If you would like to sign on to start receiving these detailed reports on the breast screening, cervical screening, and colorectal screening categories, I put the email address that you can contact and be registered through. This is a great tool in addition to the ministry reports that you can use when calculating your preventive care bonuses. The key takeaways from the preventive care best practices and appropriate billing is to submit your tracking codes regularly for every category to ensure that it is reflected on your ministry reports. The bonuses this year have to be submitted by September 10th for paper submissions and 18th if they're by EDT. And this will be for the previous fiscal year that you're billing for. Targets attained can be billed through their EMR using a mock patient or via paper. Higher levels can be resubmitted and the ministry will pay the difference. We've come to the end of the overview of the Preventive Care webinar and billing and best practices. If you have any questions, I'd be happy to take a few and discuss them with the group. Thank you. So I have a question here. Can you please confirm that we can exclude patients with a Q142 who have had a colonoscopy in the last 10 years? Yes, so for colorectal cancer screening, if a patient has had active bowel disease or has received a colonoscopy within the last 10 years, then the exclusion code then the Q142 can be used, and I will follow up individually with you in order to provide further information. So I have another question here. Which report should I be using to calculate my screening levels? In order to calculate the screening levels from the previous fiscal year, make sure you use the previous reports that the ministry issues in April. The projected one is so that you have an idea of who in your rostered patients is eligible for preventive care for the next fiscal year. And then I have one more question here, and anything else that comes in, I'd be happy to follow up individually in order to answer your questions and anything else that you may have. It was asked here, when is the ministry going to pay out the bonuses after I've submitted them? Typically, the ministry you will see it paid out on your remittance advice within 1 to 2 months after you've submitted the billings. And we'd be happy to work with you to go through your RA in order to make sure that you've been paid out the amount that you submitted for. I would like to thank everyone for joining me today for the Preventive Care webinar on billing and best practices. I hope you benefited from the webinar, and I will be reaching out individually to each of you to make sure that I can answer any questions that you may have. Thank you very much. Bye.